have the chat box using, we can also use our chat box wherever we have questions as the didactic presenter is running through our presentation for today. So once more, network, you are welcome. IT, can you share the presentation from your end? IT? Great. Thank you very much. Network. I would love to call upon Dr. Chuma Njovu, but before I call upon him, just to mention that us reaching out to you has been made possible by our able team, the IT team, with the coordination of Madam Kunda. And all these running of ECHO every Wednesday, Thursday, and Monday is actually under the leadership of Dr. Ziambo, who is our chief mentor. So once more, we really acknowledge our efforts towards the ECHO project in the country. So Dr. Chuma, please, the floor is yours.
Thanks very much, Doc, and thanks for the invitation to present on this week's ECHO. I'm not too sure if everybody can hear me. I think I just have one disclosure to make. Public service servant. Can I have the next slide? So today, the focus mostly is just on HIV and malignancies, looking at mostly the malignancies that are very common.
Dr. Chuma, your voice is quite low. We are getting you with a lot of difficulties.
You hear me now?
May you kindly work on the mic?
Is this better now?
Not really.
How about that? Okay, so I was saying that the focus is mostly on HIV and malignancies. And then just to talk briefly about some screening modalities that are used to screen for these malignancies. Next slide. So I think I'll just allow IT for an hour to run the poll question. They can just do it electronically for just a minute, sorry.
Okay. Yeah, thank you, Doc. So our poll question number one, team, the following are common HIV-associated malignancies except A, cervical cancer, B, Kaposi sarcoma, C, breast cancer, D, non-Hodgkin's lymphoma. Okay. Network, we've started seeing some responses. Dr. Njovu, so far we at 60% participation, and we'll end the poll in the next 5 seconds. So the following are common.
So like today they should have sent.
Okay, that's fine. We can end it there.
Okay. So, IT, kindly help us. We have some noise in the background. Thank you. Okay, so this is the feedback, Doc. We have 59% believing that C is the correct answer, followed by D and B as the third one. No one responded for cervical cancer. Over to you, Doc.
Okay, great. Let's run part 2 quickly, just also for 60 seconds.
Okay. So,
Or maybe everything was
question
put.
number 2, network, IT, okay. For question number 2, is the treatment of these malignancies different from those that are not HIV positive? True or false? Or yes and no? Okay. So is the treatment for these malignancies different from those that are not HIV positive? Yes or no? Okay. Very good participation. We've already 64% already have put their responses on the poll. Okay, so we are ending the poll here. Yes, Doc. So 70% believe that okay. So 70% believe that B is the correct answer, which is no. And only 30% have said yes. Over to you, Dr. Njovu. Okay, so we have our poll question number 3. Can all HIV-related cancers be screened? Yes, that is A. B, that is no. Can all HIV-related cancers be screened? A for yes, B for no. 30 seconds to go. Network, let's push in our response for this poll question. So we are ending the poll here. So 68% believe that A, which is yes, is the correct answer. Okay, so Doc, over to you. We are done with the 3 poll questions.
Okay, great. Thanks. Just move to the next slide now. The next slide. You can end the poll questions. They're still appearing. So you can end the poll questions and then, the poll quiz. Okay, so just go back now. Yeah, just the results are still showing. Go back again. Back.
Is it still showing?
Okay, it's not showing now. Okay, so we can start. So just a bit of background, that HIV patients have got actually a high risk to develop cancers compared to other general populations. And I mean, from the historical perspective, Kaposi sarcoma was the first HIV defining malignancy that was reported. And then as the years went by, cervical cancer was also added to the list, as the link between cervical cancer and HIV was very well established. And then also lymphomas joined the bracket. Now, prior to treatment, the incidence rates for all these HIV-defining malignancies were very high. But with the introduction of combined ART, there's been a very significant drop in the incidences of these malignancies. And because of the way HIV has now been controlled, people are no longer talking about HIV defining malignancies. There's been now an advent of what is called non-HIV defining malignancies, mostly because the HIV population or cohort of people are now living longer than they used to be in the previous times. And as such, they still tend to pose to have the same risk of developing malignancies as the general population. Next slide, please. So what makes the HIV population at risk of developing malignancies? So everything borders mostly on immunosuppression. So because of the immunosuppressive effect of HIV, the risk of developing malignancy from most of the oncogene directed agents tends to be higher. For instance, when there is persistence infection with oncogenic viruses, the body immunity reduces, the ability of the body immunity to sort of self-limit that viral infection tends to be waned or reduced by the immunosuppression. And because of that, there is sustained persistent infection, which ultimately leads to the production of oncogenic proteins that dysregulate the cells, ultimately culminating in the development of abnormal cells, which manifest as malignancy. This is also true for some other environmental factors. A very healthy body is able to manage and contain most of these carcinogens that humans are exposed to. But with reduced immunosuppression, that sustainability cannot be contained. And that way, it makes it susceptible for these carcinogenic factors to lead their way into the process of carcinogenesis. Next slide.
Hi, Dr. Njovu. So I've given you some slide access controls. Are you able to kindly try changing from your end?
Okay, I can see it. Thanks.
Okay, welcome.
So what's so special about HIV-related malignancies? Of course, one, they tend to occur at the age that is relatively earlier than most of the ages that you tend to see in the general populations. Secondly, they tend to have very, very atypical pathology. So with the general pathology, you find that with the HIV-related malignancies, the pathology tends to be not conventional compared to the general population. And most of the times they've been reported to be quite aggressive in the way they behave. And because they are aggressive and they divide very fast, they tend to present mostly at an advanced stage because there's compromised immunity. So because of that, the rate at which the body is going to mount the defense is relatively not as strong as the general population would be. So they tend to present at an advanced phase. So what are the management considerations when we're talking about these HIV-related malignancies? So I think one take-home point is that the treatment is the same. So there's no discrimination that because somebody has HIV, then they'll be treated differently. The same management principles have to be followed. The main catch is that a lot of considerations hello, can you hear me?
Yes, Doc, we can hear you.
Can you
Just
still hear
that,
me? Can you hear me?
Dr. Njovu?
You hear me?
Yes, please. Are you able to hear us as well?
Yes, I can. So I
Okay.
was saying that
There,
the management principles are the same as for those that do not have HIV. But of course, the key to the principles of management in these HIV patients is that a lot of consideration has to be taken into the multiple comorbid conditions that come with patients that are HIV positive. And mostly the emphasis is to make sure that the patient has got a well-reconstituted immunity, their comorbid or opportunistic infections are well managed, and that their functional status, which is graded in form of a performance status, is improved. So like in any other malignancy, the first principle is to establish that the malignancy has been confirmed with histology. And then once that is done, the next point is now to ascertain the actual stage at which that malignancy is. When the stage is verified, then what is called the stage-directed treatment is instituted. Now, this stage-directed treatment is affected mostly by the performance status of the patients, which is pretty much the functional status of the patient when they have that disease diagnosed. Of course, comorbid conditions that some of the patients tend to have in addition to being diagnosed with these malignancies. And these tend to not only alter the intention of treatment, the dose of treatment, but they also tend to pose a risk for some of the complications that are related to cancer treatment. One of the challenges, especially with HIV, is that when the disease is not controlled, it becomes quite difficult to make a certain confirmatory stage, especially radiologically, as some of the infectious related nodes that may be picked up on imaging may not be related to the cancer, but related to the disease. And as such, they may not mimic the exact stage of the cancer at that particular time, and hence compromise the specific stage-adjusted treatment that would have been employed for a particular stage in that cancer treatment.
Dr. Njovu?
Hello?
Yes, Doc. Your voice is quite low. If you may kindly see how best we can adjust it.
Okay, my sincere apologies. It's because I'm sick. So I'm not able to speak like my normal self. I apologize for that.
Okay.
I'm usually loud, very loud, and I sincerely apologize. I'll try my best. So, cervical cancer is one of HIV-related malignancies that have been established. With respect to HIV patients, they tend to be more at risk of developing cervical cancer compared to patients that do not have HIV. And of course, of note is that it's the most prevalent malignancy in our country. I mean, sadly so, because it's one of the cancers that can prevented at different levels, looking at primary, secondary, even at tertiary levels. It's mostly caused by a persistent infection with high-risk human papillomavirus. But of course, that does not mean that it's solely caused by HPV. There are certain cases where the development of this cancer is driven not only by HPV, but also confounded by factors which are not related to HPV, which mostly look at smoking, low socioeconomic status, and the previous exposure of contraceptives in vitro. So the symptoms for cervical cancer are usually dependent on the phase at which it's presenting. In the early phases, it may not even be symptomatic, but as the disease progresses, there is usually this low abdominal pain that is associated with it, compounded with irregular or abnormal vaginal bleeding, some vaginal discharge, which is usually offensive with a very foul smelling, and then painful coital activity, as well as postcoital bleeding. When it's way too advanced, it tends to affect some organs around it, which mainly include the bladder and the rectum. And in some cases, it may form a communication between these organs, forming what are medically called fistulas, where some of the functional purposes for these organs are lost and are channeled through the genitourinary tract. The treatment for cervical cancer is dependent on stage. When the disease is quite early, mostly if it's stage 1 disease, surgery is a preferred mode of treatment, especially for the very early patients that wish to, conserve their fertility and would want to give birth again. The surgical option is mostly considered. But if it's relatively advanced to a point where surgery is not feasible, then the non-surgical treatment options are considered. And in this case, a combination of chemotherapy and radiotherapy is used to treat cervical cancer. At some times when the disease has spread to other sites, for instance, if it's stage 4, with spreads to other organs that are outside where the cervix is, chemotherapy and some element of what is called biological therapy is used to treat the cervical cancer, to target not only the primary tumor around the cervix, but also the distant areas where this cancer tends to spread to. So what about screening for cervical cancer? To date, cervical cancer is the only HIV-associated malignancy that has met the criteria for the WHO criteria for diseases that are eligible to be screened. And out of the many 3 that we're going to discuss, it's only cervical cancer that has got well-established screening mechanisms. Now, one thing that is evident in HIV patients is that the pre-malignant lesions are quite common. And these are common because there is that sustained infection, persistency in infection because of the low immunity of the HIV patients. So these persistent human papilloma infections are the main driver for these pre-malignant lesions. What they do is they produce what are called oncogenic proteins, And these oncogenic proteins now numb the function of the tumor suppressor genes in a normal cell. And by so doing, they stop the regulatory function of that cell, and the cell starts dividing abnormally. Because there's no control in that cells, there's a lump of cells which are formed, and these lump of cells accumulate. The degree of accumulation is measured depending on how deep these cells embed. And as they break the basement membrane of the cells, then they become invasive and malignant. At the moment in our country, we are privileged to be able to do cervical cancer screening in pretty much across all the provinces of the nation. And previously, as you would note, we were quite versatile with the visual inspection with acetic acid, mostly because we had very limited experts that were available at the time to execute the pap smear modality of screening. Clinicians were available to take the lesions, the cells from the cervix, but the pathologists were not just that many to be able to meet the demand of the cells that are picked up from the cervix. And now we've noted the rollout of the DNA HPV testing, which has been adopted and being used as the screening modality for cervical cancer. So what about Kaposi's sarcoma? So this is one other form of an HIV-associated malignancy. Like we stated initially, it was the first HIV-associated malignancy that was reported. And it mostly is a disease that is of a low-grade soft tissue sarcoma, and mostly that comes from the vessels. Its malignancy is associated with infection with the human herpes simplex virus. And in as much as the skin tends to be involved most of the times, there is also extra skin involvement, which may look at different levels of mucous and membranes, and sometimes involving some of the vital organs of the body, like the stomach, the lung, and the upper digestive system. So the goals of treatment for Kaposi's sarcoma is mostly to palliate the disease, because to date, we haven't had the cure for Kaposi's sarcoma. So the focus mostly is to make sure that all the symptoms that it's causing are well palliated, to prevent the progression of this disease, and in so doing, making sure that the cancer shrinks, ultimately improving the quality of life for the patients. In the HIV population, the most important treatment front is ART. So when treating this type of malignancy, focus should be in reconstituting the immunity. If the immunity is not reconstituted, no matter how much non-HIV treatment you bombard, the response may not be good enough. Sometimes patient tends to respond with just immune reconstitution. So if they are not on HIV treatment, they have to be started on HIV treatment. If they've been on HIV treatment, they have to be assessed on why they are failing on that HIV treatment, and possibly switched to another line of HIV treatment that will be able to reconstitute the immunity. If by all means the first intervention of ART fails, then chemotherapy is considered. There are other situations where chemotherapy is considered directly, and mostly if the disease is very advanced, in what is called a poor risk disease by the AIDS controlled trial group staging system. If they've got extreme visceral disease that is compromising on not only the airway, but also the food pipe. If they've got cutaneous lesions that are way above 25, if they've got edema all across, and of course, if they develop what is called KS iris, they develop the iris syndrome, immune on the start of HIV, then they have to be treated with chemotherapy. Well, the other form of HIV-related malignancy is the non-Hodgkin lymphomas. Now, this is a spectrum of lymphomas that range from what is called the diffuse large B-cell to the Beckett subtype, immunoblastic subtype, the plasmoblastic subtype, and sometimes just the primary brain lymphoma. This was also noted to be associated with HIV and was science integrated in the HIV-related malignant malignancies. And more certainly is that for patients that have HIV, it tends to go to sites that are mostly not in the lymph nodal line. For instance, it goes to the stomach, the food pipe, the esophagus, and even primarily to the brain. But again, like we've seen in most other HIV-related malignancies, the incidence of most of these lymphomas have dropped. And mostly this is because of how effective HIV medication has become. And primarily, treatment for this non-Hodgkin lymphoma is also stage dependent, and mostly systemic treatment with chemotherapy is used, and sometimes radiotherapy is added to consolidate chemotherapy, especially if the response has not been very good to the primary chemotherapy. So I'll end there for now and just invite some questions regarding the three summaries of the HIV-related malignancies that we have shared. Over to you, moderator.
Thank you very much, Dr. Njovu, for this wonderful presentation. Maybe before we go to question and answers, we'll go back to our poll questions so that we assess our learning on what has been taught to us today. IT, can you go back to the poll questions? Okay, so this is our poll question number 1, network. We need your responses. So the following are common HIV-associated malignancies except A, cervical cancer, B, Kaposi sarcoma, C, breast cancer, D, non-Hodgkin's lymphoma. Which one among these four? I will read again the question. The following are common HIV-associated malignancies except, okay, is it A, cervical cancer? Is it B, Kaposi sarcoma? Is it C, breast cancer? Is it D, non-Hodgkin's lymphoma? Okay, so we are going to end the poll here. Okay. So, Dr. Njovu, 89% of our network believe that C is the correct answer, which is breast cancer. A quick comment from your end?
Thank you, Dr. Emmanuel. Yes, I mean it's shown great improvement from the first statistics in the pre-poll, and indeed 6 is the correct answer. From what we've learned today is that by and large the HIV-associated malignancies are cervical cancer, Kaposi sarcoma, and non-Hodgkin's lymphoma. I think the great thing is to note that there's been an improvement in terms of statistical percentage on the correct answer. So C is the correct one.
Thank you. So C is the correct answer. Thank you very much, Dr. Njovu. IT for number 2. Okay. Is the treatment for these malignancies different from those that are not HIV positive? Is the treatment for these malignancies different from those that are not HIV positive? A for yes, B for no. Okay. The participation is quite good, Dr. Njovu. And we shall end the poll in the next 15 seconds. Great. So we are ending the poll here. And B has gone for 82% against A, 18%. Dr. Njovu, your feedback on this poll question. Dr. Njovu, are you there? Dr. Njovu? Okay. We can go for the poll question number 3. So for poll question number 2, the treatment, according to what we've learned today, there is no difference in treatment. What was actually mentioned is that being HIV, the incidence is quite higher, and occurrence actually is there with some kind of complications which are earlier than the non-HIV. So poll question number 3, can all HIV-related cancers be screened? So A for yes and B for no. Okay. Can all HIV-related cancers be screened? We have 10 seconds to go. A for yes, B for no. Okay, so we can end the poll here. So Dr. Njovu, we have some 53% for those who are believing that yes is the correct answer, and 47% which believe that no is the correct answer. So quite a little bit tight in responses, and would love your clarity on this slide. I mean, on this poll question. Njovu?
Hi, Dr. Mungomba. So he was just switching devices. He's just joined just now. Thanks.
Okay. Great. Thank you very much, Mr. Chatonda, for this question. I have my feedback, though it is reserved network. Would love our didactic presenter to give clarity on this. Quite a tight feedback, 53% versus 47%. So would love a tiebreaker on this one. Okay, so network, we have some good questions in our chat. Okay, so we have Tine, who is asking, what is the approach in managing a cancer patient who present with severe anemia but require chemotherapy? And number 2, how does one access the slides for the various sessions? So for this one, by the virtue of you logging in on this session, if you are on iEcho directly, you have these presentations on the platform. So before Dr. Njovu comes back, Chatonda, are you able to give some clarity on the issue of slide, because this question is commonly asked?
Thank you so much, Dr. Mungomba.
On how one...
Yes, please. So actually,
yes, please go ahead.
You are right. So by virtue of participants joining using the pre-registration link we usually share, you have access to the slides using the iEcho website. So iecho.org, and then you can just look for content, and then you'll find all the content, not only for this presentation, but all the sessions we've had. Thank you.
Thank you very much for this this clarity. So Edwin, you have actually all the presentations on your phone. So it's just a matter of checking on where it is written presentations, and you'll be able to download as it has been explained. Dr. Njovu, are you back on the call?
Yes, I am. I'm sorry for the breakdown. I'm using a desktop and then power just went. So luckily this other laptop has a bit of power and I just switched to that. My apologies for that.
Okay, so just a clarity from your end on poll question number 3, where we have tight responses, 53 for yes and 47 for no. What is the response for this question? Over to you, Doc.
Yeah, so if you look at the HIV, the main HIV-related malignancies that we discussed, we focused on cervix, Kaposi's, as well as non-Hodgkin's lymphoma. Now, the WHO has established guidelines on which diseases qualify to undergo screening, and of course, what screening modalities should be used if that disease qualified to be screened. And by and large, out of the 3 HIV-related malignancies, it's only cervix that qualifies at the moment. And that's why you would see that, I mean, of course, screening should be differentiated from treatment or prevention, right? Prevention comes in at all levels, could be primary, secondary, tertiary. Even the treatment that we give is prevention, except that it's at a tertiary level. So the other two HIV malignancies, the non-Hodgkin's lymphoma and the Kaposi's sarcoma, could be prevented mostly at the tertiary level. That's where we offer treatment. But I mean, do they meet the criteria, or do we have well-established screening modalities for this type of malignancies? To date, no. So that's why the answer for that is not all of them do meet the screening criteria, but there is one of them which has got very well established screening modality, and that is cervical carcinoma. So the answer for that one is B.
Okay.
Can they be treated? Yes, they can be treated. So treatment is different. So all of them can be treated. And like I said, for instance, with Kaposi sarcoma, until now, we haven't yet found the most effective treatment which would render a radical treatment. The treatment that we give mostly is it's palliative treatment. That would need intensive treatment, firstly starting by maybe giving robust chemotherapy, consolidating with radiotherapy, and to some point even consideration of what is called a transplant in terms of stem cells. So all these treatment modalities can be effected at different levels, and this is what should be differentiated from screening. So screening and treatment are two different things. So not all of them can be screened, but all of them can be treated. I hope that clarifies. Over to you.
Thank you very much. Yeah, for this clarity. There is a question from Chuma. What is the treatment for someone who tests positive using Evelyn brush, but negative on the VIA? So that is concerning cervical cancer. So we have now brushes which are being used for screening cervical cancer. So what is your take on that one, Dr. Njovu?
So screening, remember, for cervical cancer, like we said, comes in different modalities, and their sensitivity and specificity is also different. The most specific and sensitive of the three that we talked about is the DNA HPV testing. And that's why we've seen a shift now from what used to be done previously with VIA towards DNA testing. So, I mean, all the different modalities and protocols used tend to vary on what has to be done immediately after. For instance, if you get a negative test on VIA, which is very suspicious, you would probably consider trying to use a more sensitive test, which in this case could be in form of cytology through a pap smear or a DNA HPV testing using a PCR. And these may be able to break the discordancy that comes in after. So two tests are not the same. Yes, they yield towards giving us the same information that we want, but to what extent they give us that information is different. It's more accurate with DNA than with a pap smear, and then now with a VIA testing. So Yeah, but when it comes to the actual treatment for the disease, remember what we said. The first thing is, I mean, even when we still do these screening modalities, we still have to confirm whether that disease is present or not. And that confirmation is done using a biopsy. When the biopsy is done, then it confirms that that disease is present. The next question is, if this disease is present, at what stage is this disease? That's where now the aspect of clinical evaluation, which is supported by imaging, comes in to constitute the final stage for that disease. And then when the stage is finalized, the next question is, what's the standard treatment? And now the standard treatment has to be given. And then when the standard treatment is agreed upon, the next question again is this patient fit for this standard treatment? What is the patient's interests or wishes regarding the standard treatment for this particular stage? Then now a so-called tailored treatment is finalized, and that's what is offered to the patient. Over to you, moderator.
Thank you. Thank you very much, Dr. Njovu. I was almost making a mistake without mentioning our experts on the call. Dr. Citonge, Msadambwe, Dr. Maurice Mwale, Dr. Owen, Ngalamika, Dr. Lewis Banda, and Dr. Kamfwa. One of our experts, please, may you kindly get this question, which has been asked by Mtine, who is indicated for the HPV vaccine and at what age? Any member among the experts to help us also clarify this question, which has been asked by Chuma about the poll question number 2, where he has argued that his response for yes, the reason because we give ART and other modalities, while on non-HIV related cancers, we don't give ART, but just modalities. I need explanation on this. So these 2 questions from our experts, can be unmute and go ahead. Our expert on the call. Okay, so Dr. Njovu, you'll be requested to get these 2 questions briefly. We have 2 minutes to go, so kindly get these 2 questions for the network.
Okay, I'll be quick. For the HPV vaccination who is eligible. So it's essentially anyone who's never been exposed to HPV. And one of the widely documented ways for HPV exposure is sexually. So if someone, say, is a virgin and they're 35 years old, or maybe say 25 years old, they can still get the HPV vaccine. But to our guideline, this vaccination is being given to children in the age from right about 9 to about 14 years. And the rationale behind this is that this age group has been thought not to have been exposed to any form of sexual HPV. And as such, the efficacy of the vaccine will not be compromised. So that's who's eligible. The other question regarding ARTs given to those that are positive and given to those that are not positive. Was that the question? Or would you refine the second one, the one you said from the one who said they still said yes because ART is given to?
Okay. Chuma, may you kindly unmute? I mean, is it Chuma or okay. Just a minute, Doc. I identify. Yes, it is Chuma. Chihubwe. Kindly unmute and give us what you mean.
Yes, this is Chuma. My question was on the question for number 2, where the question was, is the treatment different for the cancers? Then I was like, I wrote yes. I said yes because on the non-HIV patients, we don't give ARVs, while on the HIV patients, we give ARVs. So that's why I said the treatment is different.
Okay, yeah, thank you for that clarification. Yes, so remember the HIV treatment is being given not to treat the cancer. The HIV treatment is being given to treat the HIV. But even when the HIV treatment is being done, is there a difference in the way you treat the cancer patient in a patient who has HIV compared to someone who has no HIV? And that's why we say the answer is no. The principles of treatment are the same. Just like, for instance, if say somebody has got no HIV, they've got the cancer, but one, they've got high blood pressure, and the other one has got no HIV, but they don't have high blood pressure. The one with high blood pressure will still take high blood pressure medication to control the high blood pressure. But the principles of cancer treatment for these two people will still be the same. The only caveat, like we said, is to take note that in as much as you're treating the cancer, you have to be wary of these other comorbid conditions that they have. So you don't treat the cancer in isolation. You also have to make sure that the treatment continues for these other comorbid conditions. But the principles of treatment are the same. The same way you treat HIV, cervical cancer stage 2 in HIV is the same way you treat cervical cancer stage 2 in someone who's got no HIV. The ART will be for the HIV, and the chronic medications will be for other comorbid conditions. Okay.
Thank you, Doc. Limpo, you have your hands up in 30 seconds. Unmute.
Okay, thank you. Yeah, I just wanted to find out as a follow-up when the criteria for eligibility for HPV vaccination. So for the girls, let's say, who are aged 13 and 14, is there any further screening to ascertain eligibility, like finding out if they're already sexually active? Or we just take it that any girl who's 14 and below falling in that category should be vaccinated against HPV? I submit.
Dr. Njovu, in a minute.
Yes, remember that's, working on the pretext that by that age group, they've not been exposed to HPV. As to whether virginity tests are done, I'm not privy to that, and I'm not just, I just don't think that would be ethically right to ascertain exactly that extreme. But I mean, that doesn't mean that when they're given that primary form of prevention, then they're 100% cut off from other modalities. No, they're still eligible to also undergo screening at the right age. For instance, when they turn the age of 21, they can still go through routine screening, because the efficacy of the vaccines may not be, 100% in everyone. So yes, it renders a reduced chance of getting the cancer developing from HPV infection, but there is still that small fraction that may still escape that chance, and then augmented by routine screening that can also be picked up quite early. Okay.
Thank you very much. Dr. Njovu, we still have some good question in the chat box, but unfortunately, David, bear with us. Time, it is now 13 hours and we've passed by 2 minutes. We are required to end this call now. We really thank for your question, and it should be answered in due course. Once more, network, we urge you to actually respond to actually give your feedback so that we see how best we can improve on our echo. So the link for the feedback is in the chat. So please kindly give us kindly fill in what you feel should be done for us to improve on our project echo, and provide the feedback to it. Then lastly, next week, we are having our Monday echo. Wednesday, we'll have our long-acting echo. And again, Thursday, like today, we'll have the Sare echo. So once more, team, thank you very much for your time. For now, we are signing off. Bye-bye.